Thank you everybody for putting yourself on mute. While we begin the webinar, I'll introduce you to today's webinar. Today's moderator is DSK Rao. He will present the health challenge that this topic, community health workers, seeks to address. Our featured speakers are Mukti Bosco, who will introduce you to Healing Fields' project of promoting community health workers, which the project calls Community Health Facilitators. P.S. Hooda, who partners with Healing Fields on the Health Facilitators program for implementation. He will present CASHPOR's perspective of the program. Their presentations will be followed by an open discussion in which you are encouraged to pose questions to the speakers or for your own experiences working health workers. I'd like to introduce you to today's host of the web, DSK Rao, who I know everybody is quite familiar with. Senior executive with National Bank for Agriculture and Rural Development for a long time before joining the Microcredit Summit Campaign Educational Fund 17 years ago. DSK, let me turn the mic over to you. All right.
Okay. Thank you, Sabina. I hope you are able to hear me. Yeah. In inviting you to today's webinar, in the webinar series of the communities, integrating health and microfinance. Still, there is a debate whether everyone should be promoting health at all or commit themselves to only financial services is their core strength. I remember a meeting of most microfinance institutions. Hello.
Yep.
Yeah. Yeah. Still remember a meeting of microfinance practitioners. We, at Microcredit Summit Campaign had convened. We were attending the Access Summit about 4 years back. In that, most of the microfinance institutions were participating in that. And it was a very interesting debate among ourselves whether MFI should be promoting health or they should be combining only to financial services. So it was, rather, at that time, it was 50-50. Most of the MFIs felt that no, this is not our job. Some of them felt very passionately about it, and the clear mandate as whether it should be pursued by MFIs or not. That was about 4 or 5 years back. I think that kind of debate is now over. More MFIs, particularly MFIs, be it than Equitas, ESAs, CASHPOR, Gramin Hooda, SERDP. They are all promoting health in some or the other. They know whether they promote health or not, but the issue is how should they do it? What model they should promote? How should we do it efficiently and cost effectively? Whether they are promoting health on their own or should they be partnering with some other organization? Should they have a sort of a unified approach of deploying their credit officers for health promotion also, or they have a separate cadre for health? Issues that are now being discussed, and in that direction we have now today's is one such model that is being followed by CASHPOR in partnership with Healing Fields Foundation. Today we have a model of community health workers. Communities are designated differently by different organizations. Some community health facilitators like CASHPOR does. Somebody as community health volunteers. One calls them as Swasta Sevikas, health volunteers or health workers. Health workers are increasingly popular for health profession by health service providers. They are belonging to the local area, most are from either self-help groups or of MFIs. They have good with the rural community, but common folk are able to communicate with them very effectively. Organizations are deploying them for delivering health education, health messages. But I have gone beyond health education. Say for ESA, Microfinance, some women for livelihoods. They need them to monitor blood pressure and blood sugar, process, collect a small fees, and have a small livelihood. 1,000 health workers who not education, also some basic health. Hear about health facilitators being promoted by CASHPOR Healing Fields Foundation in UP. We have the experience in professionals. Mukti, Mrs. Bosco from Healing Fields Foundation, and Hooda of CASHPOR Microfinance. Mukti was founder and secretary of Healing Fields Foundation. She has a master's degree in healthcare management from the Administrative Staff College of India, Johns Hopkins University. She is an Ashoka Fellow. We can work as a social entrepreneur in my student space. She has several national and international awards for her work in the field of public health. Ms. S. Hooda is the Deputy Managing Director of CASHPOR Microcredit. Ms. is the General Manager of Oriental Bank of Commerce. He was the founder and director of Uttaranchal State Cooperative Bank. He was also Uttaranchal Microfinance Company, sponsored. So I now see Bosco to start.
Yeah, good evening, everybody. It's pleasure to be with all of you today to talk about our work in community health facilitation and especially focusing with our partnership with CASHPOR. I have one of my senior colleagues, Gayatri, who has been working very as a integral part of the team with Healing Fields and one of our senior most members. And she is the person that I visited CASHPOR for the first time, and we realized this whole program together. And she is in charge of the whole CASHPOR project. So what I would do is I would request Gayatri to do the presentation, and I will take any questions that you would have on the program or the project. Please, over to you.
From Healing Fields Foundation, and I'd be happy to talk to you about the program that we have done, CASHPOR, the way we approach it, the whole bit today. Can you go to slide 5, please? Yeah, we are going to talk today about our organization and how the whole partnership with CASHPOR started, and how we the whole together as a joint partnership. And then we're going to talk about the whole achievements of the program and the scale-up, how we've done the scale-up, and what are the plans for the future scale-up. And a bit about the challenges of doing a similar kind of program. What are the kind of challenges we came across and how we started them, and etc. Could we move next slide, please? The next slide. Just to give you a little bit background about Healing Fields. Healing Fields was founded in 2000 and it is registered as a not-for-profit society. And we also have SRA registration and 12A and ATG exemption. And we are also registered by CIRO as a scientific industrial research organization, and we have a very independent board who's very committed and involved in our strategy and in our work. And the vision of Healing Fields was basically to make quality healthcare accessible and affordable to all people in India, with a special focus to poor, underprivileged, and marginalized people. And with this vision, we started Healing Fields in 2000, and we started and we did a microfinance, micro health insurance program. We did a lot of work around health financing. And we move to the next slide. So we did a lot of work on health financing, and we developed a micro health insurance product also, which we had worked for 4 years. We had implemented a pilot, and a very impactful pilot. And when government started introducing subsidized micro health insurance for the poor in the form of Arogya Shri and RPY, we took a step back and we looked at what is it. I mean, it has introduced a health financing mechanism, but what is it that is needed for the poor to prevent them from falling sick and to help them to lead healthier lives? And when we started looking at that, we realized that majority of the illnesses are preventable, and it is because of lack of awareness the illnesses are high, especially in the poor communities and in the rural communities where the education levels are lesser. So that is when we said we need to start intervene from the basic primary step of creating awareness and helping people to understand better about their health and how to access quality healthcare. And on that, health financing can be built on that platform. And with this understanding, we came up with the community health model, community health education model, which is what we are doing, which is the model that we are working with CASHPOR now. The next slide. Yeah. So basically, this model, what we do is we have been working in partnership with CASHPOR from 2010. So what we did in 2010 was, on CASHPOR's invitation, we had visited CASHPOR's areas, conducted focus group discussions with the community members and with their staff. We had visited some of the hospitals and some of the healthcare facilities in their areas. We did a complete landscape study on health in areas in which CASHPOR is working, and we tested the current model to CASHPOR, where the model entails where we work in partnership with CASHPOR, identify their clients from every village. And these clients are basically, they are semi-literate women with big education and who can read and write the local language. They are clients of CASHPOR and mostly housewives who are committed to creating change in their community and have good communication. We identify them and we put them through a process of 1 year, an internship. What they do is they undergo 6 months training with us, where they come to us every month for 4 days of training, and we build the whole health education model to them as building blocks, start training them in basics of health, nutrition, sanitation, prevention of illness, and on that we start building blocks of knowledge. And by 6 months we would have trained them on the entire life cycle of health, including maternal health, child health, men's health, geriatric health, first aid, sanitation. That we would, the whole cycle we would have trained them. And this training is mainly a participatory, which follows adult learning principles. And so they, the CHWs who are clients of CASHPOR, are training from us for 6 months. 6 months, once they undergo the training, they go back to their villages and do small projects, conduct some health education sessions, small projects as in educating the children in the school on hand wash and sanitation, or bring soap pits for villages or kitchen gardens. So these kind of projects they take up for 6 months. And at the end of 6 months training, then another 6 months to intern with us. During internship, what each community health facilitator does is, 3 months of internship, she conducts 10 health education sessions in her village. She either goes into the MFI groups or any of the existing groups of 20 to 25 people, and she conducts a health education session on topics that we have given her. We have already trained her on, and we have told her to conduct sessions on these topics to the community. And these are predominantly these sessions are conducted to the microfinance group. When the microfinance groups have meetings, these sessions are conducted in those microfinance groups, and these main interventions like construction of toilets, sanitary napkins, or gardens, soap pits, all of this, and we also these help the community to form groups to save towards health. They help people save towards health, and these are called health saving groups. And and they also network hospitals where the community could access quality hair care at a discounted. This is done as a part of the health facilitator intervention in the village level. And another very critical element of the CHF work is she undergoes a basic first aid training by the Red Cross St. John's Ambulance Program, and she's certified by the Red Cross Society as a basic first aid training. On the basic first aid training, and this has actually helped a lot at the community level, where several CHWs have helped in conditions, critical conditions, and prevented loss of life and limbs several times. Help people who have poisoning, help people who have had poisoning, or people who have had snake bites, who have had fractures, to immediately resuscitate them and to help them to go immediately and access doctor and get the treatment immediately before there is further deterioration of the condition. So this is also done as a part of the community health facilitator program. So this is the basic program that we have been working on with CASHPOR, and from 2010 we started in one district of CASHPOR in Bihar, Bosco, and today we are across Bihar, UP, and we are also scaling to Jharkhand and Madhya Pradesh. I think we have about 50 batches of that we have trained across CASHPOR areas. That is 2,500 of CASHPOR's clients. Today we have trained as community health facilitators. And another element of this is to ensure commitment to the program by the women when she comes for the program, to ensure that she's committed and she continues and values the program. We charge them a fee of 100 rupees for every month that she undergoes training. So basically, she comes for the training, takes care of her own travel, comes for the training, pays 100 rupees fee, and then we take care of all the other logistics for the training.
It was an echo.
Can I move?
Go ahead, continue.
Yeah, can I continue? Yeah. So this is paid every month by the CHF for the first 6 months, and the next 6 months when the CHF is undergoing internship, and that she does an internship, we expect her to conduct 10 health education sessions in the community on predetermined schedule. We give them the schedule of the sessions to be conducted. The predetermined schedule. She conducts 10 sessions every month in the community. For this, the CHF gets paid 500 rupees honorarium every month. Apart from doing the health education sessions, she also continues on the project she's doing in terms of toilets or kitchen gardens, and continues facilitating communities to construct toilets. She conducts camps in the village. Recently, we've had the International Women's Day. So what happens is celebration of International Women's Day, all the CHWs get together in one area and they conduct health camps, community mobilization camps, where they call doctors or they call people from the health department, and it's a large gathering from the community with a specific theme. Theme could be sanitation, theme could be women's health, theme could be pregnancy, adolescent, any of the themes, and the key specific activities are done, as in it could be a health camp, it could be an awareness workshop, it could competition, poster competition, any of these, or a rally. So these activities are also done by the CHS. Apart from that, initiative that we have got through the CHS in CASHPOR areas is warm clothes initiative. The initial years when we started the program, one of the things that came up was that the extreme weather conditions in the states, Bihar and UP and those in the northern states, are very deteriorative to the health of the communities there. People fall sick, and also some of them because of the extreme weather in Bihar and UP, especially the vulnerable and the women and children. So to tackle that, what we started in 2011 in the CASHPOR areas is we started a warm cloth initiative. We did this in partnership with Goonj under their Clothes for Work program. So what we do every year is, before the winter, source warm clothes from Goonj, and the clothes are through just they are distributed to the communities, and the community pay a nominal fee for these clothes, a nominal amount for these clothes, and apart from that, a community when distributed in the community, the entire community has to come together and do a sanitation activity for the village, for the entire village. Like the community comes together and cleans the drains, or build soak pits in a village to reduce the stagnation of water, or they come together and do any of the sanitation, clear drinking water source of the village. So the kind of sanitation activities the community gets together and does in return of the warm clothes. Now, they are getting this for the they're doing this for warm clothes. The reason they pay the nominal fee is they use this nominal fee collected from the community to pay the CHF for the efforts she puts in getting the community, distributing the clothes, and also in gathering the community, distributing the clothes, and also in doing the sanitation activities. But towards that, CHF also gets paid something. Now, apart from that, the one very nice element of partnership with CASHPOR.
Excuse me. I think you have 2 minutes time.
Sure. I'll move on.
Please,
one important element of partnership with CASHPOR was the equal commitment from CASHPOR, where they start an extended internship program, which is beyond the 1 year. They continue with the CHS and use the CHS to educate their clients exclusively for 1 year, and the CHS are paid an income through CASHPOR, paid a fee through CASHPOR. Now I will move on to the So the journey of the CHF already. So I'm moving on to the impact of the program. Impact evaluation of the program. Slide 13, please. Yeah. So now that I have talked about the whole program at an outline, we have, since it has been 5 years since we've started the implementation of the program, 2015, we had done an external evaluation of the program, and it was an independent evaluation done by Dr. J.P. Williams, who was former principal of CMC Vellore, and this was done at CASHPOR areas, where it was a comparative study, random evaluation with the comparative study, where CHFs, intervention villages where the CHFs have intervened were compared to CHF non-intervention villages, and the results that came with that is most of the impact has been much higher in intervention villages compared to non-intervention villages. For example, in the intervention villages, we've had high institutional delivery and the referral to the hospital was majority done by the CHFs, and we've had first aid interventions by the CHF. Use of sanitary napkins was much higher in the intervention villages. And another very important thing that came up from the evaluation was that there was an increased respect for CHFs, both within the country and from the village post the training. And also there has been an increased earning for the CHFs who were earlier housewives who had very marginal income. Yeah, and so this I would like you to go into the slide, slide 18.
Okay.
Sorry, not 18. Sorry, 16.
Okay.
Okay. So apart from the evaluation done by Dr. Jay Prakash Mulyal, we've also had an impact assessment done by Deloitte. This was again an independent impact assessment. It was done in 2016, and it was done in the areas where we've done the program with CASHPOR. That also very clearly showed that there has been an increased participation decision making for the CHS. This focuses on the CHS. There has been an increased autonomy for the CHS, and there is confidence has increased, and the element of the CHS in the village level discussions was also much higher for this program. And I would like you to go into the slide 19, please. So now, having done all of this, having built up this resource in the village level, the community health facilitator who's been able to create an impact, who's been able to bring out health behavior change, we have strategized moving to the next level. So if you see, as of now, we have equipped CHWs and established them as go-to persons in the village level as health advisors. We would like to elevate them as community health entrepreneurs and as basic care providers and enable them to have sustainable incomes. So I would just like to little bit talk about what this basic care provider is. So the last year we have had a partnership with Department of Emergency Medicine of Stanford University, and they have partnered with them basically to take the CHF program to the next level. Today the CHFs are basically the primary contact points. Well, they create awareness and they help the people in preventing illness. But the next level where we are seeing the CHFs and going to is they are the first point any healthcare situation in the village. They will be able to identify illnesses, diagnose the conditions based on the symptoms, and give immediate care and help them to make appropriate referrals. And to do this, we have partnered with Stanford Emergency Medical Department. I have already done a program where they train and develop lay health providers in the communities, especially in areas where access to healthcare is very limited, and they have done pilots in African countries and Haiti. A similar program they have brought to us, and we have identified 50 women from Bihar and UP. We have done a pilot. We have trained these 50 women. We have given them hands-on training, and we've also given them classroom sessions, and they were trained by master trainers of healing fields who were directly trained by Stanford. And these women have completed their training, and today these women, they take the history, take the vitals of the patients who come to them, and go the symptoms and understand, identify what the illness is, and give the primary care needed, like whether it is stressing or dressing or some basic treatment they are able to give, and then make the appropriate referrals. So this is the pilot that we have just started, and we would like to scale this to the other areas with the support of Stanford.
Guys, I think, please.
Yeah, you let me to. Yeah. Just this last point I'd like to add and stop it with your.
Yeah. Yeah.
Yeah. So this this is, I'm sorry, when I start talking about our work, I get carried away.
Yeah,
This is one element of the second curve. The other element is a livelihood program, where we are working in partnership with some organizations where we are trying to create. We have done a livelihood market study. We have identified what are the kind of health-related products that these CHWs, community health resources, could sell, make an income for themselves. And now we are going to launch that program shortly, where CHWs would be able to market health products within their villages and make an income for themselves and sustain the work that they are doing.
Yeah, the rest we can cover under question answer session. Thank you so much.
So that basically the whole idea of the second curve is that. Yeah, thank you.
Thank you. Mr. Hooda?
Yes.
Yeah,
Please.
thank you.
So thank you, Gayatri, for such a nice detailing of CASHPOR Thinkfield program. You have really you have made my work quite easier. You are talking about the feasibility. Yes, of course, I'll be focused on the viability. Good afternoon, friends. I'll be taking you through next 7 slides. I'll be talking mainly on the schedule on the CHF, and then the cost involved in that, and how the project went forward. But first of all, let me talk about being a MFI person. I have to focus upon this program. In fact, is a business sense. Being a finance people, we have to see that everything has to be viable. For the business detail, let me also introduce you about the CASHPOR itself, the 675 company again, like Healing Field. We have membership of around 12 lakh clients in 64 very backward districts of Bihar, UP, MP, Jharkhand, and Chhattisgarh. We are operating. Since something more than that, we are working with the real poor, not I'm talking about the poor for the this poverty line. Our clients are very poor to the absolute poor, but you can say. So still, everybody knows that every 16th Indian is on average is ill. Actually, Gayatri says that 60 to 70% of those ailments can be avoided by awareness, and what this program does, and really has done it, as the guy has covered many of the impact points. Again, these poor people, they spend 2% of their income. And also, something very serious, about 50 is they spend only 10%, 5% amount of that, and 15 they comes around 5. So 85% of the total health expenses goes to the working couple, and clearly indicates that most of these ailments there is a wage losses. Definitely, if they are able to work in the field, they are not in a position to utilize the loans, and in fact, there's lesser demand for the loans, bigger loans. So that's a real thing, and we have high people talk about. It is no demand at all because of the ailments. So by these experiences, if you are able to keep them healthy and having more working hours, and there will be a good demand for the credit. Two, they're utilizing it, earning more income, and the faster they will be coming out of the poverty. So, MFI see that the health of a client is the base for a good MFI business. In our case, CASHPOR Thinkfield Foundation collaboration with our CHW program. No doubt, it's a really privilege to partner with the Hillfield Foundation. You have three so well, even at the top level, sometimes CASHPOR feels we are the MI part of Hillfield Foundation. I mean, a health agency. And say nice congregation of this activity at the CHF level. CHF, who herself is a client, she known from realize the relate back and she makes creates an example in front of other fellow members, and that's a good MFI business foundation is created. Whole process, what CASHPOR does, we do the selection of these good clients who are 8th pass and relatively good in communication, more friendly or more developed leadership among the members, and of course we do share costs, and then we take further this program along with Hillfield Foundation. Next page. Okay. Please next. Yeah. So what cost on this program? Now this is a point. Around 37,000 rupees is the total cost on this total training and internship part of this CHF program. Of course, another thereafter having fully trained to deliver modules, around 15 modules to 10 to 12 centers. We pay around 100 rupees per month, and that comes around 15,000 to 18,000 a year. Client coverage in total, 120 clients are normally covered through their internship program, 1 to 50 after completion of their internship and training. So total officially comes around 370 families. And these 370 families, if you make a cost of 50,000 total, comes around less than 150, I mean a total 148. The outcome, we have details in a nice way, a good slides and independent that has been done by Dr. Mulyali. But the number we have mentioned here, no doubt there is at least reduction, if not reduction, at least sustenance of health expenses wherever this CHWs are working. Of the clients, outreach for the CHW program has been around 50% of our clients. It's a time to take it forward. This has contributed many more. My finance friends, MFI people will be with me the last 3-4 months, right from November to March, and in the end of demonetization. CHWs play a key role wherever they are. We did not find any default. So finally, I agree that the CHWs creating awareness not only for health, as Gayatri was talking about, sourcing also many products like mainly on the sanitary napkin. Since then, after awareness, we have gone to the next level of having mini health clinic sessions at fortnightly interval at our branches. And these CHWs play a key role in getting a patient to that place and getting them the health services. Financial literacy is another thing they do it. So, no, as per cash experience, this is really wonderful, and CASHPOR feels that of course we need to go higher level. Gayatri was talking about more things. That too, awareness has no limit. The second round of awareness, if it continues, it's going to give a not only good help to the client, but to make this opportunity for MFIs. Thank
you. Thank you, Mr. Hooda. So we have a few questions now. let me pose the first question to Sri and Mukti. Mitra Datta of Freedom from Hungary is asking how CHF costs could be covered going forward.
Going forward, I'm assuming that beyond the CHF program itself, the community health facilitator program is more like an investment. So as of now, when we start with CASHPOR until now, it feels is to provide the training. And the kind of training that will be provided, we have to look at it as investment and a lot of investment for the microfinance. And going forward, you have heard Gayatri talk about the CHF paying 100 rupees for the first 6 months of the training. Now we have something called the BCP program, the Basic Care Provider program, where the trained women are paid 4,000 rupees for getting additional training and for the first aid kit. So therefore, that would be the model where it will have to be part granted, part from possibly the CSR funds of the MFIs as well as other CSR activities, or for that matter, even with the government itself. If you're expecting it to be sustainable on its own, to my understanding, sustainable is if you're expecting the MFI member, the individual CHF to bear cost, I think that would be overseas as of now.
About revenue model, and until is asking who 500 rupees per month during the internship. There is some confusion in the sense that you are paying 500 rupees to them and they are also paying 100 rupees per month. I think a little clarity.
The first 6 months, for the first 6 months, the CHF program is a 1-year program. The first 6 months, the CHF, community health facilitators, who are CASHPOR, they 100 rupees. This is more for value creation. And the next 6 months, which we call it as internship, with very specific activities that they will be carrying it out in the community, they get paid 50 rupees per session. So they are expected to do 10 sessions. So on average, they get paid about 500 rupees per month. This is also built into the grant model. If I understand correctly, when you talk about a revenue model, you are talking about a for-profit model, you will be talking about a return on investment model, and you will, I'm assuming, talking about the cost of financing. Gayatri talked about upfront. Fields Foundation is a not-for-profit organization. So, and also the other aspect is this is training, like primary care, education, at a policy level, will have to be grant funded. So if you're talking about a revenue model, no, there is no revenue model. The revenue model come in place, that too for the women, for the BCP, not for us as an organization, but because we are not working towards that. For women, it will, when they become a basic care provider, where they get additional skill sets to be able to provide possibly treatment and care at the community level, as well as when they start selling products and services. For example, the sanitary napkins that they sell, as well as what Mr. Hooda very beautifully talked about, the initial marketing of other products that the MFI has in CASHPOR. They have experimented using the CHS to provide financial literacy training, as well as to be the brand ambassadors at the community level of being able to provide additional training for health-related loans that's available with CASHPOR, and for surveys that they use them. So a whole lot of other products that they use. CASHPOR has also initially done cost-benefit analysis of using the CHF to provide the health education vis-a-vis a staff, and what they found, what CASHPOR found was using a CHF, a community health facilitator, is far, far cheaper, cost-wise, when you talk talk about financial wise, as well as building a brand and leaving a person behind, individual who is true, having to be able to provide not just information, but also provide first aid and also create access to products and services that was not available earlier. Hello.
So after the first 6 months of training, did you have to filter some of them for the 6 months of you have to pay them? No.
They have to filter because our training in the first 6 months is pretty. We have 4 days of training. Many places the CHWs have never met each other. They are from a batch consisting of 50 to 60 women and who have been picked up from 50 to 60 villages, even though they have been CASHPOR's client for a couple of years before, but they belong to different villages. They have never even met each other. At one place at a central location, and they also are trained. It's an adult learning principle, a lot of interactive training. There's a lot of supervision by field coordinators and training coordinators and hand holding. In case we see that there is a particular person who is lagging, then additional training is provided to that particular person. We, as much as possible, try and make sure that the CHWs whom we recruit in the first month, there is a dropout of about 15%, which we take into consideration when we are recruiting the CHWs, selecting the CHWs, because this is, this kind of attrition, even in the MFI, some of the staff also happens. And so we do see it to 15 to 20%. Attrition because of a separation, either because there are some health issues in the family, or they have migrated, or there's a death in the family, or possibly the husband and in-laws cannot support them. These are, or they may have left the MFI. They may have not anymore a member of CASHPOR. So these 5 reasons that we see that there is a dropout. I have to ask anybody to leave.
There are some more questions of Mukti. One is from M. Krill, health entrepreneurship. He would like to hear a little more about what sort of enterprises are being taken up. You have briefly touched upon that. I would like to know whether you would like to add more regarding what sort of enterprises are being taken up. Again, most of these questions are related to sustainability.
Sure.
Yeah,
sure. The curve, as Gayatri said, is to establish and to be making these women independent and be entrepreneurs. Microfinance is all about entrepreneurship. This is what I believe microfinance is all about. And the loans that the women take is for micro enterprises that they start off at home. So piggybacking on that, what we thought was we start off with sanitary napkins, and we saw that the uptake has been very good. We have not been able to produce enough for the women to be able to sell it. And we also have experimented. The more that what we do, we do a pilot, we learn from that, and we start scaling up. So now we believe that our women are capable. So we are putting in an entrepreneurship training. So in the 6 months of internship that we have, we are going to be integrating the entrepreneurship training, because that involves a whole lot of different areas that we do not cover. Like, for example, project planning. It is more like inventory control, or in terms of marketing and sales and stores. All of this, as well as income versus profit versus loss statement. How do you do accounting and all of this? And so we have identified different products and services that these women can potentially sell, a basket of products and services. One, that is the BCP program, the basic care provider. These women learn how to do the vitals that Gayatri talked about, blood glucometers, pulse oximeters, suturing, splinting, wound care, referrals into the hospitals, using a mobile app to be able to figure out the decision support and be able to, on the mobile, order for the medications that they would require. Of course, all of it is backed and supported by a qualified doctor, because legally in India, any prescription has to be with the qualified doctor. One of the services that the women will be providing for a fee. The second one is we plan to scale up sanitary napkins. Right now, I have not decided whether it has to be production or we outsource it to somebody else, and we start selling the scaling up the sanitary napkin, because we have seen we are just not able to keep up with the demand in the market. So that is the second product that will be sold. The third product, we already are in the last stages of tying up with one of the FMCG companies, where we would be supplying certain health-related products like hygiene products. When I say hygiene products, it could be soaps, it could be toothpaste and toothbrush. Like, as you know, oral care is another huge issue among the poor. So oral care, we are also talking to Vision Spring in terms of having a partnership in terms of using their, spreading their glasses.
Yeah.
I mean, there's a whole lot of products and services. Possibly insurance services is something that we look at, which can be rolled out. So ultimately, what we will be providing the woman is anything between 3,000 to 5,000, again, depending on the entrepreneurial skill of a particular woman. Yeah.
I mean,
yes.
for achieving that kind of sustainability of 3,000 to 5,000 rupees per month for each of these CHFs, roughly, on average, how do you think it takes? 1, 2 years, 3 years? Well,
yeah, because of our experience of having been able to scale up rapidly with CASHPOR. CASHPOR has been one of our fantastic partners who have been supportive. And one of the things that I would like to tell to this group is, unless there is a commitment from top down, from the board, from the CEO downwards, this program will not be effective. And that is something that we have seen. We have worked with a whole lot of other microfinance. We have worked with CASHPOR, and what we have seen is CASHPOR is extremely committed, top to bottom. Each one of them know the program. Each one of them know their roles and responsibilities, and be able to support the program. So that goes a long way in doing a program. And I mean, as we see it, we should be able to hit the mark of 3,000 to 5,000 in 2 years with just the first year of the program. If I haven't given the different our women, what we have seen is there are a whole lot of women who are innately entrepreneurial, and they have been working an income of even 10,000 rupees, because what they have done is, one of the major things as a byproduct that we have seen is that women get confidence of being able to present in front of big groups of people, being able to go and speak to the district magistrate or the district medical officer or the PSC or the Swachh Bharat project director, whoever, and that gives them a huge confidence, and therefore they get a lot more entrepreneurial ideas. For example, the panchayat and the project directors of Swachh Bharat missions have used our women to construct projects, and they have earned income between 3,000 to 5,000 without too much of intervention from us after they have finished the program. There are a lot of women that we taught them. They have made it their best, in spite of being small holding farmers. They have ahead and sold the vegetables, and they have earned an income. We have some of them who have been actively involved in surveys, not just with CASHPOR, with the government agencies, and they have earned about 5,000 to 10,000. But average, if we want 60% of the CHS rate to earn an income of 3,000 to 5,000, I'd say anything between 2 to 3 years, including the CHF training.
Very encouraging. Very encouraging. I have a question to Mr. Hooda. I mean, we are all now convinced about, after all, CASHPOR has run with this program for the last 6-7 years, and we understand your commitment. And one question asked to you is, will the is being covered as part of for CSR funds, or have any plan of doing that in the future?
Dr. Rao, in fact, cost is one. The cost is very minimum. Two, they are doing so many things. They are so benefited as Mukti ji says. They are our ambassador in the field. Of head offices in Banaras, they were in Jharkhand and Chhattisgarh remote. They present CASHPOR. They being there, as I told you, they have done the miracles from November this to in the sum of this monetization. These people came forward and they kept these so many rumors away. That was a CASHPOR only who was least affected by this demonetization. So CHF is always useful, and many other things they do for CASHPOR, like surveys, like even many other health products, as Madam was saying regarding health and sanitation project. We give money them for that also. CASHPOR is getting business indirectly and directly. They are contributing to health and sanitation environment where diseases also will be not coming forward. It is assumed.
Yeah, there is a possibility that increasingly in the future, CASHPOR might compensate their services that are being derived by you.
Yeah, in fact, this is going to be a biggest tool for microfinance as well.
But once in Hooda sir, one of the questions is that the cost that you projected as 39,000 rupees per teacher for 1 year of training. I understand it's 1 year of training. That is the question is that it is very, very high cost, and is there any way we meet that cost even without funding support, or should it always have to be the first 1 year of expenditure on the CHF has to come from the grant, and then subsequently they become sustainable, or the MFI could increasingly come forward to compensate. So the cost is very high. It's bothering some of the participants, and they are asking questions on that.
39,000, 36, 36.
Can I please come in here?
Yeah.
Can I please come in here?
Yeah, quickly.
Yeah.
Some more questions, Mukti.
Things which I would want to bring into notice is the first pilot, that the first three batches of 180 the first two batches of 100 CHF training was 100% support by CASHPOR. Let Hooda talk about the rest.
What I want to say, Dr. Rao, we have seen some of these CHFs before training and after 1 year training. This nothing really. So changed. They are so technical they become after this training and internship. After that, they are so useful for CASHPOR clients to really and avoiding the incidents. So cost is really nothing. Really.
Good. Once you are convinced that it is nothing, then you will definitely have some way of raising that cost.
But one question. The great work by our Healing Field Foundation.
Sir, can I? So you consider this cost as an investment you're making on your clients, is it?
Yes.
May I know who is asking the question, please?
Yes, sir. Me, Gayatri.
Yes, madam. Please go ahead.
Are you looking at this as an investment on your client? Thank you.
There is one question. I think either CASHPOR or Healing Fields, any one of you could answer. In terms of their work, CHFs how are they engaging? Engaging with the range of other health activists in the villages like ANMs and RRs. Is there any interaction between the CHFs? Are they working to supplement the work of ASHAs, or are they two independent channels?
Yeah. Question, and this is a question that we keep getting answered in every forum, where is an ASHA worker, why CHF? One of the things that we need to understand is ASHA focuses on mental and child health and also focuses on adolescent health, whereas the CHF focuses on a whole range of other things apart from the maternal child health and also adolescent health. And we have very consciously stayed away from duplicating what other health activists do in the community.
Is there any scope for synergy between them?
There's a lot of synergy. Now, if you go to the field into the villages where we have our CHF, they work very closely with the ASHA worker and with the A&M. Many times the ASHA worker or the A&M is not in the village. She's outside of the village. And it is our CHF that they reach out to identify pregnant women, to be able to identify and take them for checkups. The woman is pregnant and she gets into labor. Many times it is our CHF who call the A&M and the ASHA worker and takes them to the hospital. So there is a lot of synergy, a lot of bonding that happens between the ASHA workers, the health activists in the community, and our CHF. One of the things is that from day one of our program, we always tell our CHF, we are not here to do a program, we are not here to be in competition with what is happening from the government. We are here to facilitate and strengthen the existing systems of the government. So if you have a sanitary napkin that is sold to an adolescent girl by the ASHA worker, please educate the community on that so that you can, the community, the adolescent girl can get the sanitary napkin from the ASHA worker. There is a tablet that is given by the ASHA worker to the adolescent girls. Many a times, neither does the ASHA worker knows about it, nor the adolescent girl. So what the job of the CHF is to educate the adolescent girls why they should be taking iron tablets and also refer them to ASHA worker to be able to access that. Same happens with the PHC. When what are the entitlements from the government? So our CHS only give the knowledge, take the process, and create demand on the government systems, whether it is at a village level, or it is at panchayat level, or at the district level. So till date, we have not come across anywhere where there is a conflict between what CHF does and what the activists do. The government health activists do. They use our CHF, and many times they have come and thanked us for doing this training. Actually, today what we see is many of the ASHA workers have applied to be part of the CHF training. With CASHPOR clients, they have a whole lot of ASHA workers who have our CHF training in spite of completing the ASHA worker training.
There's one question about sanitation and the construction of the toilets. How do you cope with the government departments on the toilet construction and release of subsidies? Or, is any way you are coordinating with the local government functions?
In fact, this is a bridge loan, Dr. Rao.
Mm-hmm.
And our CHF does the main role of persuading the clients to go for such loans and tell them regarding subsidy as well as a loan from us.
Mm-hmm.
So government gives subsidy after a long time. Then there is a loan facility, Microfinance, MFI.
Okay. Yeah, please go ahead.
In fact, through these CSFs, we have been able to finance. That's without doubt. A goal is being created and again without default. The segment we are working with, the poor, very poor, you just can think that a hut and a house, then in day people go for sanitation toilet, construction toilet. That's the great work done by the CHFs only. Otherwise, how one can go for? They go for and they are being benefited.
Good. Last question. I think this is from my side. And some of our MFI friends may be interested to know. His foundation is now working in UP and Bihar. So, which other parts of India, if MFI is interested and comes forward to adopt your model, in which other parts of the country, his foundation has capacity to part with MFIs and implement schemes?
The program is so modular that we can work in any part of India because the entire processes, all of it has been built, and in any part of we have already worked in Assam, we have worked in Chhattisgarh, we have worked in Jharkhand, we have worked in Karnataka, and we have worked in Tamil Nadu also. But the program is developed in such a way that we can partner with any MFI or any organization in any state in India, and with some preparation time in terms of getting the staff there and integrating the local specific things, we can start the program in any location.
Okay. Thank you very much. Both of you have spoke so passionately about, all these days, we know that many MFIs are promoting community health volunteers, but always there has been an element of doubt about the sustainability and how they will be and dropouts, and is it ever possible for them to become sustainable and some income of 2,000, 3,000 per month. I mean, that element of doubt many of us have had, and your presentation has been very, very convincing that it is a feasible and viable model for the MFIs and SG promoting organizations to take up. Very much, Mr. Hooda and me and Gayatri. Also, thanks for all the participants. Thank you.
Thank you very much. Thank you very much.
Thank you. And also one final technical note. Thank you to everyone who has joined us. The webinar is recorded, so we will send around an email after the event is over with a link to where you can download the webinar, the video, in case you'd like to share it with your colleagues. Very much.
Thank you.
Thank you. Bye. I'm speaking to Anurag. Okay. Because there was a big group of PHFI from Lucknow office, and I had a glimpse of their district. And thank you so much. It was good. Really, I'm